Hello and welcome to the Parkinson's Foundation program, Parkinson's Disease 101. I'm Nancy Nealon, the Community Program Manager for the New York, New Jersey chapter of the Parkinson's Foundation. The foundation is very pleased to be bringing this program to all of you in the greater Binghamton area and beyond. And we are beyond today as well. Thanks to all of you who've joined us from the Southern Tier and across the country. Next, I'd like to take just a moment to give a big shout out to our sponsors who make so much of this possible. Many thanks to Acadia and Kiowa Kernan, our silver sponsors, followed by Medtronic and Synovian. Many thanks, friends, for all of your support on the silver level. And we're also very fortunate to have two exhibitors sponsors as well, Accordia and Lumbeck. Many thanks to both of them, and many thanks to all of your support. For our viewers, if you're wondering how you can access information about our great sponsors, all you need to do is go to our chapter webpage, www.parkinson.org/NYNJ. If you want to type in chapter supporters, you can do that, but you'll find chapter supporters right on our landing page too. So I encourage you to go ahead and visit and explore all the great information from our supporters, both silver and exhibitors. Before we get rolling today, we thought we would do kind of an interesting poll since it's the season. Just checking in, wanted to know, what are your plans for Thanksgiving? Are you thinking about cooking your own turkey? Maybe you're letting those kids or grandkids cook for you instead, or maybe they're delivering it to you. How about takeout? Or there's still time, you're still deciding. What do you think? Let us know what you think by voting and casting your vote now. Pretty active, lots of people cooking their own turkey. I think we're probably, yep, okay, 74%. Wow, kudos to all of you for cooking that bird. No one's getting takeout so far, and like me, some are still deciding. So thank you all for participating in our poll. So next up, I'd like to just take a moment or two and tell you all about what the Parkinson's Foundation offers and what we're about. So what we do is that our mission is to make lives better for people living with Parkinson's disease by improving care and advancing treatment today until there's a tomorrow without the disease. In everything we do, we build on the energy, experience, and passion of the global Parkinson's community. For today, for tomorrow, for us all. For today, the foundation offers an outstanding array of information in a number of formats: booklets, podcasts, website pages, fact sheets, a wonderful helpline staffed by great talented specialists, webinars like what we're doing today, and more, including our Aware and Care Kit for hospitalizations. Please contact our helpline or our website, and you'll get that information a lot today during this webinar. And I encourage anyone who's been diagnosed 5 years or less to please contact our helpline and request the newly diagnosed packet, Building a Better Life with Parkinson's. There's so much you can access for all of these sources. And for tomorrow, one of our very special initiatives is called PD Generation. Individuals who participate will be helping scientists in the journey to advance our understanding of Parkinson's, leading to new, more effective therapies. If you'd like to learn more about participating, contact our helpline or visit parkinson.org/pdgeneration. For all of us, what we do is so important, and part of what makes that possible is Moving Day, a walk for Parkinson's. It's been virtual, of course, for the last few months, but it's so important and we plan to do more. Moving Day is a powerful testament to the power and support of the Parkinson's community. To learn more about Moving Day, visit movingdaywalk.org, or if you're in either vicinity of Central New York or Westchester, We have April dates for you that are posted right there on the slide as well. So thank you very much. There'll be a little bit more about more Parkinson Foundation information at the end of the program. And right now, I'd like to invite Katie Amodeo, Dr. Catherine Amodeo, to share her screen. And while she's doing that, it's my pleasure to introduce Dr. Amodeo for our program today. Dr. Amodeo is a neurologist for the Mid-Hudson Regional Hospital, Westchester Medical Center, Poughkeepsie, New York. She's also assistant professor of neurology, New York Medical College School of Medicine. Dr. Amodeo is a neurologist who specializes in the diagnosis and care of patients with neurodegenerative movement and cognitive disorders, including Parkinson's disease and dementia with Lewy bodies. She completed her fellowship training at the University of Rochester as a selected Edmund J. Safra Michael J. Fox Foundation Fellow. During this time, she was mentored and trained by faculty in both the Movement Disorders Center, which is a Parkinson's Foundation Center of Excellence, and the Memory Care Program. She has served as principal investigator and co-investigator in several clinical trials in Parkinson's disease and dementia with Lewy bodies. Dr. Amodeo evaluates and treats patients with neurological disorders, and we are so pleased to welcome her today. Dr. Amodeo, at this point, I'd like to turn it over to you for the program and encourage everyone to continue to submit your questions.
Thank you, Nancy. All right, so we'll get started. And I'm just going to first start with what will we cover today, okay? So we're going to talk about what is Parkinson's? What does it look like? What are the symptoms, the features? Then we'll move to what causes it. Why do some people get Parkinson's and some people don't? We'll talk about how we manage our therapeutic approach to Parkinson's, and then research initiatives, things that are going on right now. And then lastly, I'll have Nancy again come to talk about support and resources, which you heard a lot about. All right. So first we'll get started. What is Parkinson's? So just a little bit about the statistics. Okay, this is a common disease. It's the second most common neurodegenerative disease after Alzheimer's. Neurodegenerative meaning it's a neurologic or brain disorder that we know is progressive, okay? And again, it's common. 1 million people in the US, 10 million worldwide are living with Parkinson's. 60,000 Americans are diagnosed each year. Most people are diagnosed in their 60s. We know that Parkinson's is largely a disease of aging. As we get older, that's where the risk or prevalence goes up. Interestingly, there is a sex discrepancy where men are 1.5 times more likely to have Parkinson's than women. And while we just said it's a disease of older age, as we get older, there are 100,000 people in the US living with what we call young onset. That's when you're diagnosed younger than the age of 50. So we do know that there are younger cases. So what is it? Again, like I said, it's a neurodegenerative disorder, meaning it's a brain disorder that progresses over time. That means symptoms can worsen over time and new symptoms may emerge. Now, when I say that, I want us to know that when it comes to Parkinson's, it's a slowly progressive, by and large, it's a slowly progressive disease. It's characterized by both motor and non-motor features. The motor features are ones I think that we're most familiar with, or we think about most often when we think about Parkinson's. That's that tremor, slowness of movement, stiffness, but it's increasingly recognized that there are also non-motor features, okay? And these can sometimes be more significant for some people. Again, everybody's different. And that may include mood disorders like depression or anxiety, or cognitive impairment. Again, not everybody will have that, but we do know that it can occur. Unfortunately, there's no cure to Parkinson's right now. We're trying, and that's where the research initiatives that we'll get to are so exciting right now, but we don't have a cure yet. What we can do is help manage symptoms, okay? The symptoms can be treated. Lifestyle interventions. like exercise, are so important. And what's so cool and awesome about exercise is that it is disease modifying. It can slow down the progression of disease in Parkinson's. I see it. My patients who exercise, they look the same from visit to visit. So it can actually change the course. With Parkinson's, we call it, it's a heterogeneous disease, meaning it looks different for everyone. Each individual can experience Parkinson's very differently. And so that's something important to keep in mind. If you know somebody with Parkinson's and you've been diagnosed, your disease course is going to look very different than that person. So everybody's different, okay? And with the right expert care, the right lifestyle modifications on your part and support, you can live, a very long life. Like I said, this is a slowly progressive disease and often does not impact longevity, okay? And so the purpose of this slide is to talk about the 10 common features that we think about when we think about Parkinson's. And again, some of you may be familiar with these. Some of these features may be what we call prodromal or premotor, meaning they can occur years before the onset of the motor features. And these 10 features are what you're often going to be asked about, and what I want you and your loved ones to keep in mind as we're thinking about this diagnosis. So tremor is the one I think that people think of most often with Parkinson's. It's that characteristic tremor at rest. So the hand or leg shaking. Now, what's important to know is not everybody with Parkinson's will have tremor, though. Actually, about half of people will not. So while it is considered a common, key feature of Parkinson's, not everybody with Parkinson's has tremor, okay? Key features are slowness of movement, small decrement in movement. A key example of how this might manifest is smaller handwriting, micrographia, where the movements get smaller, so the handwriting gets smaller, or maybe not as legible. Loss of sense of smell or anosmia. This is one of those features that may be present years before the onset of the motor symptoms. And some people notice this, and maybe they've been going to their ear, nose, and throat doctor because they think there's a sinus issue. Or some people don't notice this until we talk about it. And, then the loved one might say, yeah, he or she doesn't seem to smell, my perfume anymore, things like that. It may also be noticed by reduction in your taste. So maybe food doesn't taste the same way. But that's a key feature. We think that it actually starts years before the onset of the motor features. Trouble with sleeping. This can manifest as, in ways of insomnia, maybe more fragmented sleep. Or it can manifest as something that we think that's specific for Parkinson's and related disorders. That's called dream enactment or REM behavior disorder. When we're in the stages of sleep, known as REM, REM, we're supposed to be completely atonic or not having tone so that we don't act out our dreams. That's safe. But unfortunately, in Parkinson's, some people may actually will not experience that atonia and can act out their dreams. And this is something that we think is pretty specific. And this is something that we think can occur years before the onset of the motor features. So it's something that we're always asking about. Again, trouble with movement, slowness with movement, shorter steps with walking. That's another feature. Constipation, that's a non-specific symptom that a lot of people may just experience as we get older. But when there's a clear change in your bowel movements and there's more constipation, that can be a signal that there's not only slowing of your movement, but slowing of the gut. A softer voice, hypophonia, where it's harder to project your voice. Masked face or hypomimia, we call it, where somebody's just less expressive. You may notice this in pictures. Your physician may notice it, your specialist may notice it by looking and seeing a reduced blink rate. But that's another key feature. Some people may experience dizziness with standing, or we call that orthostatic hypotension, where when you go from sitting to standing, you get a little dizzy because of blood pressure changes. And then stooped posture. This is one that sometimes bring somebody to our attention in the office where their loved ones are noticing that they just don't stand up as straight, they're more stooped. So those are 10 key features. They're not all of them, but these are ones that when people think about Parkinson's, these are the symptoms that are most often encountered. So what's happening? Why is this happening? What's happening at the level of the brain? And while we don't know specifically what causes Parkinson's, what we do know is that there's this loss of particular neurons in the brain, these nerve cells that produce the neurotransmitter or the chemical messenger called dopamine. And dopamine is the neurotransmitter that helps with our movement, our control of movement, our speed of movement, our ease of movement. And we know that it's reduced. So the cells that make dopamine are lost in Parkinson's disease over time. Those cells reside in what's called the substantia nigra. So you may have heard that term. That's part in the brain stem where these nerves mostly live, these neurons live. And like I said, dopamine, while it is the key player in the motor features, it also plays a role in other features of the disease, such as issues with sleep, issues with our bowel motility, so constipation. Dopamine is important for attention, and so cognition can be impacted. And dopamine plays a role in our mood, so mood can be impacted. So when there is a mood disturbance, it's important to understand that it's not just sometimes a reaction to having the disease or being diagnosed. It can actually be a feature of the disease. And again, it may be present before the onset of the motor features. So we talked about dopamine, that's really the key player, but we know, especially the more we learn about Parkinson's, that there are other parts of the brain involved, and there are other neurons and neurotransmitters involved. And those are norepinephrine, which is important in autonomic nervous system function, so constipation, blood pressure control. We know acetylcholine is reduced in Parkinson's, so cells that make acetylcholine are down. Acetylcholine is important when we think about memory, attention, level of alertness. Serotonin is also reduced in Parkinson's, or can be, and that's our neurotransmitter involved with our mood primarily. And so that's why, again, you can see that Parkinson's is not just a motor disease, there are non-motor features too. And what researchers are doing right now is working on ways to stop or slow down the cell loss, these neuronal death. Okay. So how is Parkinson's diagnosed? How do we diagnose Parkinson's disease? Unfortunately, and I get asked this a lot in my clinical practice, unfortunately, we don't have a blood test or a definitive test that we say, okay, we checked your blood, you have Parkinson's. We don't have that. The way the diagnosis is made largely is based on clinical impression. So, and we can do this with actually very high confidence based on, what we know about the disease and how, somebody's history and exam present can really support the diagnosis. So, a neurologist or movement specialist can usually make this diagnosis just based on history and exam alone and do so with good confidence. Now, the only way we can be 100% certain is, by actually looking at brain tissue, which we don't do. We don't take brain tissue from living patients, but certainly that's something, patients or families may decide after one has passed that they want an autopsy. That's the only way we can be 100% sure at this time. But like I said, we're pretty good at just doing this clinically. When there's a question, there is this imaging modality that's available now. It's called the DAT scan, and it's a fancy CAT scan that basically allows for tracing of a radio tracer that binds to dopaminergic cells and will show if there's a reduction in the brain. And that can help support the diagnosis in maybe a situation where it's a little bit clinically uncertain. Not everybody has to get a DAT scan to be diagnosed. And then there are these, like I said, we're looking for motor features and non-motor features. There are scales that allow us to rate specific features, the motor features of the disease, such as the Unified Parkinson's Disease Rating Scale. We not only use these in office to monitor symptoms, but these are mostly used actually in clinical trials where we're able to really monitor and systematically rate somebody's symptoms, particularly over time. Okay. So what are the symptoms? We've talked a lot about this already, but like I said, we know that there are motor and non-motor features. The motor features are the slowness of movement or bradykinesia, the stiffness or rigidity, tremor, the key being that it's a tremor that's at rest. You may notice it when you're doing something, but the key is that that tremor is present when you're simply at rest. We may see postural instability or a tendency for one to fall. This is often not an early feature, although like I said, everybody's different. It tends to be a feature that we see later in some people as the disease progresses. And then when we talk about non-motor, we've talked a lot about these already, but there may be mood disturbances, anxiety and depression. There may be cognitive changes, attention issues with short-term recall, executive function, or that planning, multi-step tasking. It affects many systems of the body. So like I said, it can affect your GI system with constipation, can affect the olfactory bulb and may do so early. So there's reduced sense of smell. It can affect the sleep centers of our brain. And so people can have this dream enactment or insomnia. Symptoms vary from person to person, and everybody, like I said, the disease is very different for each person. These symptoms typically progress slowly and develop slowly over time. So a little bit more on the movement symptoms, like we talked about not everybody with Parkinson's will have tremor. This says 70%. In the literature, I think it's a little bit more variable, but 50 to 70% of individuals will have tremor. Not everybody does. It may be in the hand, it may be in your leg, it may be in the jaw. It may be in all of those things. Slowness or trouble with movement, stiffness, rigidity, maybe in your arms, legs, neck, hips. Sometimes people talk about, that's an early feature for them, is that they have hip pain and they're not sure why. And sometimes that may be that stiffness. Problems with walking and balance we talked about. And then the non-motor features, like I said, can sometimes be more significant for some people. And that can be depression, anxiety, apathy, or this loss of motivation or lack of interest, meaning the person isn't depressed, they just have this lack of initiative. And so that's called apathy. And some people may experience this. Trouble with thinking. So we talked about the domains of attention, memory, orientation, the way we see ourselves in our environment may be impacted in Parkinson's for some people. And some people may have trouble with other features like soft speech, sleeping, fatigue. Fatigue can be a pretty common feature of Parkinson's. And then some people may develop hallucinations, and you may have seen commercials about this. Not everybody will, but some people may develop this. So what causes Parkinson's? And the big question that I always get is why? Why did I get this? Why do some people get it and some people don't? And that really is a question that would, earn somebody a Nobel Prize. We don't fully know. We don't fully know why some people get it and some people don't. What we do know is that it's most likely multifactorial, meaning it's a combination of the genes you were born with interacting with environmental and lifestyle influences. So, getting older, like we said, aging, we think is a risk factor for Parkinson's. Maybe, we're learning more about pesticide exposure, where somebody lived with maybe runoff from somebody, from farmland. We don't fully know, but we're learning more and more about that. Lifestyle influences. So, like I said, exercise can modify your risk. So we know there are things that you can do to help modify your risk. But it's, like I said, we think it's a combination of all these things. We've been identifying in the field more genes that we think are linked to Parkinson's. But with that said, by and large, this disease is considered idiopathic, meaning not caused by a hereditary cause. And when even the genes that we have identified, some people have those genes and don't develop Parkinson's. So again, it's this interaction of all three components, we think, that ultimately leads to Parkinson's. So environmental exposures, we talked about pesticides, heavy metals. So we're always asking about occupational history, or certainly if, be thinking about those things when you're giving a history to somebody. Were you in Vietnam? There is good evidence to support Agent Orange as a possible risk. Biological, like we said, age is the biggest risk factor. There's this sex discrepancy, so being male tends to increase risk. And then genetics. This is just showing that this is unfortunately a common disease, and certainly in the more densely populated areas of the world, we see a higher prevalence of Parkinson's. And it's something to think about, what's going on in the Northeast. Again, these are more highly populated states, and certainly we see Parkinson's in other areas like California, which again are more densely populated. This is really showing that it's a common disease. And so what can we do? How do we manage Parkinson's? And really, as I always tell my patients, it's twofold, okay? Non-pharmacologic approaches or non-medication approaches, and pharmacologic medications. They're both very important as we think about how to address these symptoms and allow somebody to live their best life. That's what we want. So exercise is the most important thing you can do, okay? It's the only thing we have right now that's actually disease modifying. It can slow progression of disease down, and so it's vital. And it can be any form of exercise. Find something you like, okay? Data after data is overwhelmingly positive. Physical therapy is crucial, particularly early in the disease, but as the disease marches along, it's so important for helping with balance and gait. Occupational therapy can be really helpful when we're thinking about the fine motor tasks. So brushing your teeth, doing your buttons, tremor. I have some patients who, particularly early, they primarily manage their tremor with occupational therapy and learning ways to help their tremor from a non-pharmacologic standpoint. Speech therapy for helping with that hypomimia, or that softness of voice, and sometimes swallowing can be impacted, and so speech therapy is very important. Counseling and therapy, particularly as we think about how common depression and anxiety can be in Parkinson's, and so it's vital. So non-pharmacologic, I can't say enough, it's so important. And then pharmacologic, again, very important as we think about how to achieve, living your best life, and that may require medications, and medications that treat both motor and also ones that address the non-motor features, such as mood, such as orthostatic hypotension, and we'll talk more about that. And then for some people, they may be candidates for advanced or surgical options, which we'll talk about today. Okay, so when we talk about medications, we'll start with medications that target the motor features. And like we said, dopamine is that key neurotransmitter behind the motor features in Parkinson's. And so the goal of medication therapy is to replenish dopamine, to try to replace the dopamine in your body, mimic the action of endogenous dopamine that we all make. And the goal is, what this medication can help with is that stiffness, the speed of movement or slowness of movement. And for some people, it can help with tremor as well. And so we give it in the form of levodopa. Most often it's given with carbidopa levodopa, or Sinemet, you may hear it called. And so levodopa is the key medication. But there are other medicines that we can use either alone or as adjunctive therapy with levodopa. And those are dopamine agonists like pramipexole or Requip. What it does is it acts like dopamine. So it's like a dopamine mimic in a way. And then there are medicines that help extend the life of dopamine. So they impact the metabolism of dopamine, how fast it's broken down. And so these are medicines that block those agents that break down dopamine to keep it around longer. And those are MOB inhibitors like Azilect, and then COMT inhibitors like Comtan, you may be familiar with. And so as the disease marches along for some people, people can experience what's called motor fluctuations, where, you know, they're taking their medicine, and while they used to be relatively stable throughout the day with their features, they would take, you know, as long as they were taking their medicine, they were pretty much always the same, or what we call on throughout the day. On is a term we use to describe how you are at your best. When the medicine is working for you, you're able to move the way you want to, without too much side effect, because sometimes people can experience side effect from medicine, such as these extra movements or dyskinesia. Now, on can fluctuate with what's called off. Off is where, you know, maybe the benefits of the medicine have worn off. And so your motor features, that tremor, the slowness of movement, is worsening. And so we call that on when things are well controlled, and then off where things are less well controlled. And some people may experience these dips and peaks throughout the day. When that occurs, despite optimizing medicine, which always be talking to your doctors about other options, but when that occurs, sometimes there are other options called deep brain stimulation is one, where we can actually use stimulation in the brain to help level out those peaks and valleys, allow the on time to be longer, so it can work with your medicine. Sometimes it can help reduce your medicine, but often people need to be on their medicine still. You often need some levodopa on board as well, but this can act to kind of smooth out those peaks and valleys. Another option is called duopa, and it's a way of allowing for continuous delivery of levodopa into your body through a PEG tube, a tube in the stomach or your intestine that allows for continuous delivery of dopamine. And then something that we're hearing more about, that's under more research, some centers are doing this already, but focused ultrasound. And we talked about how these can be used to help fluctuations, or these on off, but deep brain stimulation and focused ultrasound can also be indicated in individuals who have persistent tremor. So the tremor that never really responded to medicine, that's where these other options can be useful. Surgery isn't right for everyone. So, you know, if this is something, you know, you're thinking about, certainly talk to your doctor. And it's never actually, people sometimes think, oh, I'm not there yet. It's never too early to talk about this. And actually data is supporting earlier consideration. So it's never too early to talk about, even just to start conversation and be like, okay, maybe that's something I'd be interested in. All right, so now we'll talk about how we treat non-motor features. And certainly when we think about the different features that we can see in Parkinson's, treatment is geared toward those specific things. So with constipation, the mainstay is hydration. I often say, are you drinking water? So at least 2 liters of water a day. Sounds like a lot, but that's really what we're all supposed to drink. But particularly in Parkinson's, stay well hydrated. Fiber. And sometimes people need a bowel regimen. Sometimes that can be prunes, but sometimes something like Miralax can be helpful. Mood symptoms. So like we said, depression, anxiety can be common features. And so therapy, socialization, which is hard during a time like now where we're asked to socially distance, but you know, by you being here today and participating in this symposium, and even if it's virtually, is excellent. So the worst thing to do is to disengage. Remain socially engaged in some way safely. Exercise. Exercise can do wonders for mood. It can actually change the neurochemistry. But then sometimes we need medication, and I don't want people to feel ashamed by that, because like I said, we know it's part of this disease where serotonin may be reduced. And so we use medications like serotonin reuptake inhibitors, or SNRIs, serotonin norepinephrine reuptake inhibitors, to help with mood. Okay. And then sleep disturbances. Obstructive sleep apnea is actually disproportionately more common in Parkinson's and related syndromes. So, don't overlook that, and make sure that you're asking about that and being screened for that, because that might be a reason for sleep disturbance. Okay. And then when we think about dream enactment, the mainstay is actually melatonin, because we know that there's a disruption in melatonin, and by using melatonin in the literature, it's actually very beneficial for helping with the dream enactment. With the orthostasis, and I know there were some pre-symposium questions on this, that's that postural lightheadedness or dizziness when you go from sitting to standing or change position. May also occur when you're eating a meal and all the blood is being moved to your gut and away from the head, so people can get dizzy. And so first thing to do is to make sure we're looking at the medications you're already on, because antihypertensives or medicines used for blood pressure can put you at risk for this or exacerbate it. Diuretics or medicines used for prostate hypertrophy like Flomax can also exacerbate it. Also, the medicines we use to treat your Parkinson's symptoms can also worsen orthostasis. So be sure we're having discussions about that. We may just need to tweak the medicines a little bit. Again, water, 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 drink, stay hydrated. That can really help combat this by increasing your volume. What I tell patients, and sometimes they're surprised by this, but I said, you probably have never been told this before, but I'm saying you can be a little bit more liberal with your salt. Okay, so salt helps you hold on to volume, and so it helps reduce these fluctuations in blood pressure. And let's see, and then ways to help mitigate changes in blood pressure when you're laying down, because when you lay down, your brain actually tells your body to lower your blood pressure, or sometimes what can happen in Parkinson's is it actually causes it to get too high. So then your brain, your body's trying to regulate that when you get up in the morning, and your blood pressure may be too low. So actually, by elevating your head of the bed at night by like 15-30 degrees can help regulate that and help avoid those big changes in blood pressure. And then there are medications that can be used to help. These are medications, their role is to basically help with volume expansion so that you're not getting these drops. And then when we talk about cognitive impairment, again, there's medication and non-medication approaches. Diet. The most evidence we have is for the Mediterranean diet. What are they eating in Italy tonight in the French Riviera? That's fish, extra virgin olive oil, fruits, vegetables, less red meat, less sugar. So sugar is inflammatory to the brain. And so we know that diets that focus away from that are healthier diets for the brain and actually are neuroprotective. Okay. Exercise. We talked about, I don't think we can talk enough about exercise, but it helps with everything. It helps with your motor features, your mood, and it helps with cognition. There's some literature to support exercising the brain as well. So doing some cognitive tasks in therapy. And this is especially important during a time of COVID where we're asked to socially distance. I was relying a lot on this actually, as patients weren't allowed to see their loved ones or socially engage. So I said, do puzzles, make a little garden on your windowsill, something that's a novel task that's getting your brain building new connections, okay, helping with neuroplasticity. That is what socialization does for us. So people are interesting and we learn from people, and that helps our cognitive function. So doing it in some way safely right now, okay, which is phones or virtual or small gatherings. Strategies are so important. And so that's also where occupational therapy or speech therapy can be helpful by helping with strategies to help with your cognition. So a calendar, a medication alert bracelet, something, okay, they can really be helpful for helping you through this feature. And then there are medications. So our most evidence are for these acetylcholinesterase inhibitors. So we talked about how acetylcholine can be down in Parkinson's. And so these medications help keep it around, okay? And so Exelon is the one that's FDA approved. when there's Parkinson's disease with dementia or more severe cognitive impairment. And then I also often use donepezil. And then, like I said, not everybody will experience this, but some people will experience hallucinations and delusions. It can be, less severe or minor phenomenon, like seeing a shadow go by, or it can be more well-formed, actually seeing a person that isn't really there. Everybody's different, okay? Not everyone will experience this. When somebody, does experience this, the first thing to do, especially if it's new for them, is to look for a possible trigger. Is there an infection, a UTI, particularly because we know that our bowel and bladder can be impacted in Parkinson's. Our loved ones are often at risk for this. So a UTI can be enough to cause hallucinations or changes in thinking. So we always want to make sure that we're not missing that. So you may, when you call into your doctor or see your doctor, you may often hear them saying, make sure that there's not an infection. Okay. Dehydration, water, your brain likes water. It needs to be bathed in water. So being dehydrated can be enough to trigger this change in our thinking and mental status and cause psychosis or hallucinations. Other metabolic disturbances can as well. And then medications, and that may include the medicine we're using again to help you with your motor features. We're giving you, back dopamine, and dopamine can cause hallucinations. And so again, it's this discussion with your doctor. And again, what I want to say is that we don't think it's just the dopamine that causes. We think it's both disease progression and medicine sometimes in some people. And then, when it's more chronic and persistent, we've tried to optimize these other things, but it's still there. People are still experiencing hallucinations. Again, the first thing you want to try are non-pharmacologic approaches, like with orientation, validation. So sometimes I say, it's okay to say, oh, yes, I see that too. I told them to go away. You know your loved one best, and there's different ways to help. But sometimes we need medicine, and acetylcholinesterase inhibitors that help with cognition can be very helpful for hallucinations. But then there are other medicines that help, specifically for hallucinations and delusions. And the only 3 that are safe to use in Parkinson's, they're of the antipsychotic class, so anti-hallucinations, we'll say. The only 3 that are safe to use from that class are quetiapine or Seroquel, Clozaril, or Clozaril, and then pimavanserin or Nuplazid. It's the newer agent on the block, and it can be very effective for helping hallucinations safely in somebody with Parkinson's. And then again, exercise, we can't say enough, right? It's so important. The most evidence is for at least 2.5 hours a week of some combination of cardio and weight training are the most effective. And there are so many, and you can learn so much more about this from the Parkinson's Foundation as well, but there are lots of ways to get involved with exercise. We have a picture of somebody doing boxing. Boxing has really taken the Parkinson's community by storm because it does all of the things that we know to be beneficial in one exercise. So it does cardio, it does balance training, it does strength training in one exercise. And so it can be very helpful, but certainly there are other things you can do. Dancing, ballroom dancing, yoga, walking, any of it is so beneficial. And it's, like I said, it's the one thing we have that can really modify this disease. And the other thing is thinking about your care team. So find a doctor who is an expert in Parkinson's. A movement disorder specialist is who you're looking for. So that's a neurologist who has been trained with additional training in movement disorders, and we tend to mostly see Parkinson's disease. So again, finding your right care team is is very important, and resources like the Parkinson's Foundation can be helpful for that. If there's not one near you or you're just not familiar with one, they can help, okay? And it takes a village. It's not just one person. It's your specialist working with you and your care partner at home, but also we have physical therapists, occupational therapists, speech therapists, nursing, palliative care. There's so many people that may be a part of your care team, and it's whatever you need to help you live your best life. Okay. And then, like we said, unfortunately, depression, anxiety are common, and they can really impact one's overall health and well-being. And so this is so important to always be talking about with your doctor. There are resources, like we said, both therapy or non-pharmacologic approaches with a therapist or a social worker, but also we may need to use medication as well. And then also, what I often tell my families is, while I'm also a specialist for the patient with Parkinson's, I'm also there for the family, for the care partner. And so it's so important to also be seeking support for you as the care partner as well. Okay. And there are support groups, but we have to be taking care of everybody. And so lastly, we'll talk about research. This is, really the exciting part. What's being done? What is being done to help combat this disease? And so research is important because it's what allows us to improve care. It's the reason, we talk about all these treatments that we have and all the things we know about Parkinson's. That all comes from research. And so it's what's advancing us forward, coming up with new treatments. It improves day-to-day life and brings us closer to a cure. So if there's, any way that one could be involved, I say, if it's right for you, then do it. It's really how we're going to move forward. And so this is just showing that sometimes we have trouble recruiting. And so, without participants, we really can't do research. So, I encourage you to try to get involved. There, clinicaltrials.gov goes through all the different trials that are going on. You can just search Parkinson's disease. You can search a feature of Parkinson's. So there's studies going on with anxiety in Parkinson's. There's studies going on with sleep disturbances in Parkinson's. And so you can look up these different trials that you may be interested in. And then an easy way to get involved is just to join this genetics initiative. So it's, Nancy talked a little bit about this, but PD generation, it's really an amazing effort, a national effort to allow us to advance our understanding of the interplay between genes and Parkinson's. And at no cost to you or the participant, you can basically be hooked up with a genetic counselor and get genetic testing. And this can be done in person or at home. So you can actually do a telemed visit and then get an at-home testing kit. And again, this is really understanding this, and as well as other features of the disease, are really how we move forward. And so with that, I will end.
Well, that was quite the marathon, Dr. Amodeo. Let me just give you hopefully a moment or two to catch your breath, maybe grab a sip of water, whatever you need to do. That was a lot of information, which hopefully answered a lot of questions for people already, but we still do have some wonderful questions that I think, have plenty of time to get to today. So when you're ready, Dr. Amodeo, is there any advantage to being diagnosed early?
So excellent question. And I actually just attended a webinar myself on this, about, especially as we're moving forward with thinking about and developing disease modifying trials. I think this question is going to be even more important and more of a forefront, but there is. And I think for many reasons. One is, so even though we don't have a cure right now, I think there are still benefits for early recognition and early diagnosis. One of that may just simply be starting to change your lifestyle, starting to implement more exercise, eat better. So we did a survey where they asked patients, if I had known earlier, what would I have done? And they said, I would have implemented exercise and disease modifying therapies a lot earlier. Additionally, I think it's helpful for just even planning, future planning. What does my retirement look like? I would have modified my stressors in my life a lot sooner. I wouldn't have been worried about work so much. You know what I mean? So I actually think there is benefit. So yeah. And especially as we hopefully, like I said, develop cures, it's going to be so important.
Advancing treatments, cures, absolutely. I think another really important question here, and we do address it a bit in the actual slide deck, but certainly that doesn't give people, 1, 2, 3, here's what you should do. But if someone were to ask you, what's the best place in New York to be evaluated if you have symptoms, what would you tell them?
Oh my goodness, that's a great question. So, and I don't know if there's a best place. So obviously I was trained in Rochester, so I love it. But there's so many experts down in New York City. There's experts, well, here and where I am in Poughkeepsie, the Hudson Valley. There's, I think there's experts in Albany. They're really Syracuse. I mean, the list goes on and on. I think one thing I've been fortunate about living in New York and training in New York is I've met so many experts that are passionate and excellent. And so I think you're in good hands just being in New York. And I think using the resource of Parkinson's Foundation to find these centers of excellence. And if you can get established with a center of excellence, you're in very good hands.
That's absolutely. I was going to
follow up.
To that effect. And it's worth noting for those of us who are residents of New York State, we are very fortunate to have a high number of movement disorder specialists in our state. There are some states in our country that maybe have one movement disorder specialist in the entire state. The Centers of Excellence from the Parkinson's Foundation, a great place to be able to check into. And you can find, if you're not within New York State, you can check with our helpline to see where you might find the closest one. But a movement disorder specialist is that person who really specifically evaluates and treats people with Parkinson's. So one of the other things I want to come back to, Dr. Amodeo, is person asked, or you did a great job describing boxing as it relates to exercise. If there's anyone new here, though, with us today, they might be just scratching their head and thinking, boxing, oh my goodness, why would I want to get in a ring and, have somebody try and hit me?
Yes.
So I thought maybe could we take just a moment or two to explain perhaps a little bit more about what, for example, rock steady boxing, that's not the only one, but that's a popular one, how that all works, and certainly more a little bit about exercise in general, but let me stop there and have you perhaps give some response to that.
Yeah, and I'll do my best, but yes. Right. So I often get asked that when I bring up boxing, like, well, I don't want to hit anybody. No, you will not be, it's not a contact sport, it's with a bag. So they use a bag to help with these movements. And basically thinking about what boxing or kickboxing exercise is what they do. Now, it's different for everybody. And actually one thing that I think is amazing about, particularly I know rock steady boxing being one, they evaluate you to see where you are in your disease course. And they sometimes will contact your neurologist for input, but they really, gear your therapy toward where you are. And so, I encourage you to not be discouraged if maybe you're somebody who's a little further along, or if you're somebody who's newly diagnosed thinking, I don't need that. There are different stages of classes. So I know I had patients who were in a wheelchair who were doing boxing. So it's really an incredible way of getting exercise, like I said, which is great. What's great about it is that I think it does all the things in one. Right. So it helps with postural balance. It helps with big movements. We know that helping, there's a whole nother avenue called like big and loud therapy, which is so valuable. It does that. It does cardio, so it gets your heart rate up, which we know, like I said, some combination of cardio and this weight training or strength training is so important. And so that's just one, but like you said, there are so many other ways. And we know that any level, any intensity is helpful. So even from doing yard rock around the house, while that maybe isn't as strong as, say, doing more intensive exercise, it's still better than nothing. So anything we know is beneficial.
And like today, the fact that we are virtual and not in person, the same is true for many people in their exercise programs, which has been a tremendous loss for people with Parkinson's. So I'd like to encourage you that there are many things that are online you can access, like you're accessing this today, including online boxing programs. And I'm going to highlight Fitness Fridays, which is part of our programs, and we'll get to that a little bit later. So thank you for that. I think that was a great explanation of why that type of thing works so well. Talk a little bit, I'm going to go back a little bit to symptom management here. So what developments or drugs can be used to help with people who have leg freezing or motion interruption? And maybe you could explain freezing in and of itself, because I don't think we got into that
Yeah, we
too
didn't.
much.
You're right. I didn't. So freezing of gait, we call it, or most often it's called fog or freezing of gait, but certainly people can experience freezing in other ways where they just can't initiate movement. Most often it presents as with walking. So somebody might be walking and then they change their threshold. So maybe go through a doorway, or the carpet changes to hardwood. Something like that can actually trigger what's called a freezing. And again, not for everybody, but some people, where they just can't take another step. They're kind of stuck. Sometimes we can see that more in when somebody's experiencing off. We talked a little bit about off time. So you might have more freezing of gait when you're off. Sometimes people have it just when they're initiating gait. So they're just getting up to start walking and they can't start. Sometimes they have it when they're making turns. So everybody can experience different times. We know that there are some factors that may make it worse. So off being one of them. So when you're maybe not at your optimal time of your medication dosing, or if you're anxious or stressed, that can also exacerbate it. And what's complicated about that is freezing of gait can interplay with anxiety too. So it's figuring that out. But so what we know to be the most effective treatment for freezing, again, twofold. So physical therapy and cueing actually are very beneficial for freezing of gait, and actually are what our, first line treatment is. And so one thing, so working with physical therapists who can say a lot more than I can, but one thing I know from talking to physical therapists and working with patients is you basically want to give yourself a cue to override that abnormal message. So for some reason, your body is sending a message saying you can't move. So you want to override it. And so one thing I say is picture stepping over something. So sometimes it's actually putting a visual cue, like a piece of yellow tape down where you tend to experience freezing of gait in the bathroom, for example. Or some people have rolling walkers that have a laser function. So if you can use that laser function and then tell yourself, step over that, initiate a bigger, more dramatic movement that's safe, can actually help override that abnormal message. So cueing can be really helpful. Square steps, so thinking about especially if the freezing happens with turning, so thinking about doing one big step, one square step, another square step, another square step until you complete the turn can help. There's some interesting YouTube videos of a patient who had freezing of gait, and then they started kicking this ball on a rope and they were able to walk better. So that's, again, that cueing and overriding that can be really helpful. Now, if the freezing of gait happens more when you're off, then sometimes it's optimizing your medications to help. I had a patient who was having a lot of freezing of gait with a lot of fluctuations, and actually when they started Duopa, that continuous form of levodopa, they had less freezing of gait. So it's really, it can be optimizing your medicine and physical therapy that are really the best treatments.
Have you ever had any patients tell you that singing helps them break the freeze?
So yes, so I'm singing, marching in place, counting to 10. Yes, it's again, it's interesting, but it's kind of like overriding. Yeah.
So maybe would this be correct that just like Parkinson's is not the same in any two people, you kind of have to try these things and see what works best for you?
Yes.
It could be different things.
And especially if anxiety is playing a role too, be open about that, because sometimes treating the anxiety can help too.
Okay. So another symptom management related question, but more so on the non-motor end. And I think that at least people have told me that this can be pretty scary. Can we talk just a few more moments about delusions or hallucinations, and what could be most helpful for people? How do we try and take the anxiety out of that?
Yeah, yes. So for some people, the delusions, which may be paranoia, which may be thoughts about spousal infidelity, things, it can really present differently, or hallucinations, can be upsetting, and can be linked with anxiety. Now, there are some people who experience these things and it's not upsetting to them. So again, it's kind of having those conversations, and I'll say, do these scare you or do they not? And I've had some patients say, oh, I see a bunny, but I don't mind it. I like it, So with those, obviously we can just reassure this is part of Parkinson's. It's okay, or maybe not for everybody. Okay, so in the situations where they're more anxiety provoking or upsetting to the care partner, that's where we can employ strategies to help. And so obviously we talked about pharmacologic. Sometimes you need medication to help, or sometimes it's optimizing the medicines you're on or reducing them. But then when we talk about non-pharmacologic, which is actually, again, the one first line in most cases, is there's different strategies. So one can be, reassurance. And again, your loved one best. For some people, this might not work, but for some, you would say, oh, what do you see? Or why do you think that? That's not true. That's, for some people, that might be upsetting. So then, like I said, validation can be helpful. So if your loved one is seeing something out the window and they're convinced that something is there, I'll say, then go up to it and say, oops, I opened the window, I told them to go away, they're gone. And sometimes that can be enough. Or I've had, some patients say they were really worried about their daughter and they just wanted to talk to them and call them because they knew something was happening that wasn't really happening. But so we say, then go ahead, call the daughter and just, or you can even pretend to, especially if it's late at night, and just, pick up the phone and say, yep, everything's okay, great. So there's things you can do. Other things that can be really helpful are distraction. So distracting to a different behavior or thought. Music therapy can be very helpful, particularly music from a time that was maybe your anniversary, time of your wedding, a time of when maybe your loved one was working. To kind of bring them back to this time that's more soothing to them. Music therapy can be really helpful. And then other things, what I also hear is there's certain people that can help in the family, and there's, or maybe an aide that's more helpful at times. So, I say it's okay to take a step back and maybe call on help from somebody else. And then, of course, if you ever feel like your loved one is in danger or you're in danger, then don't hesitate to call 911 or physician for help.
Absolutely. Okay, thank you for expanding on that. Let's talk a little bit more about genetics. And we have a viewer who has a twin sister, and the person is asking, should she be tested for Parkinson's? Is she at risk?
Yeah, great question. I'm an identical twin too, so I always have a special place for twins. So it's a great question in that, we know that twins, whether fraternal or identical more so, being 99.9% the same genetic makeup, it's very compelling to think, if somebody has the genes for Parkinson's, then your twin is also carrying those genes. But this is where Parkinson's is complicated, in that you can have the gene and not develop Parkinson's. So they're not deterministic genes. And that's, for example, like in a disease like Huntington's, where we know if you have the gene, you're going to get it. It's not like that in Parkinson's. You can have the gene and never, one of the genes that we know of, which could be LRRK, there's other ones, you can have that and never develop Parkinson's. And so it may be the case that your twin is not going to go on to develop Parkinson's. We don't know. And I think when you ask about genetic testing, I think it's definitely a question to talk about. And that's where I think this PD gene generation can be really helpful in that you never want to go into genetic testing. I would say this, you don't want to go into genetic testing without proper counseling. And that's why I think it's so important to have genetic counseling and gene testing, because you want to know, what does it mean? What does that mean for me? And like I said, having the gene in the situation of Parkinson's doesn't mean you're going to get it, but you want to know, you want to have the right support and the right information. So if it's something you want to do with your twin sister, I think it's a conversation to be had. But certainly I would get genetic counseling as well.
And actually, Dr. Amodeo, you just touched on an important part of our initiative with PD generation. There is counseling that is just part of the overall product.
I think is great.
So you're absolutely right. It's not just a cheek swab or whatever.
Right.
And they have made big steps so that it can continue despite the fact that we're living through this pandemic.
Yes, that's awesome, because I do caution people against being tested without that. Yeah.
Makes sense. We also have a couple questions. If you could go back and elaborate a little bit more on the low blood pressure and that issue, because that certainly can be very, very challenging and put people at risk for falls and such.
Yes. So a lot of what we talked about today is that there's not just motor features, there's non-motor, and a lot of that can be dysautonomia, or changes in our autonomic nervous system in Parkinson's, often manifesting as constipation, but also very commonly manifesting as orthostatic hypotension, or that change in blood pressure with standing. And so what we know happens in some, and like I said, it's pretty common, about 40% we think of patients with Parkinson's will have this, is when you go to stand up, what should happen is when somebody goes sitting and they go to stand up, their heart rate increases and their blood vessels tighten so that the blood gets pumped up to your head, because your brain needs to be perfused. And so your body has these mechanisms in place to basically get the blood up there when you stand up, so that you don't have this drop in perfusion with gravity, because the gravity changes. So it keeps the blood up there. Now in Parkinson's, that process can be delayed or slowed. And so when somebody goes to stand up, that those mechanisms take longer. And so the blood can pool lower in the body, so in the legs, and can cause somebody to be kind of dizzy while their blood is going up there. So it's taking a little bit longer to perfuse the head. So people can get dizzy. People can also just sometimes get neck pain. Sometimes people can get a headache. Sometimes people may pass out because, again, because of that momentarily reduction in blood pressure. A mechanism that's in place is to kind of shut things down a little bit, so people can actually lose consciousness and pass out. So obviously we don't want that to happen, because that could be dangerous and lead to falls. And that's where, when you go to your doctor, they're, asking, they should be asking about it, but then you should also be keeping note of that. Do I get dizzy? And that's where be really proactive about it, because we don't want it to be so dramatic that you're passing out. That's where we need to think about treating it. And there's lots of different approaches, like I said. Compression stockings I didn't talk about, but compression stockings are actually abdominal binders that help keep the blood up when you stand up, can be really helpful too.
And Dr. Amodeo, would wooziness, dizziness, maybe even something that lasts a long time, all day, is that something that could fall under this? I know I'm probably asking a very difficult question to answer.
It's a great question. It may. So people who experience wooziness or dizziness throughout the day, the first thing I'd be worried about is blood pressure, or a side effect from a medicine or something, but certainly it may be. And so, what I often do is I'll ask patients to kind of keep a diary of their blood pressure, so that I see if there's these fluctuations.
So in other words, let your doctor know what's happening.
Yes, please. Yes, let them know. Don't have to live with this alone. And we can treat it. It actually is. It can be very effectively treated.
Great. Okay. Another non-motor symptom that can be quite disconcerting, and perhaps more so to the partner or the care partner, is the REM sleep disorder. Could you elaborate on that a little bit more, what that looks like?
Yeah. So this, like I said, this can be a feature that can occur years before the onset of the motor features. So I'll often hear, oh, but they've been acting out their dream for 20 years. So it may be, or it may be something that comes along with Parkinson's as you're diagnosed. And it can really, again, like everything we talked about, it can very much vary. So women actually tend to be less active. And so it's often misdiagnosed or underdiagnosed in women, because women tend to just kind of talk in their sleep. Maybe they're talking out or yelling out, or their movements are a lot less aggressive. So they might not even become to the awareness of their bed partner. Now, there are some people, and again, this tends to be more so in men, but it can be in both, that are more active in their sleep. So they may actually be dreaming about running away from a lion, and they're actually running in their sleep and may run out of bed. You may be dreaming about punching or boxing from your boxing classes, and you can actually, people will be boxing in their sleep. They're asleep, so they're not awake, they're not aware that this is happening, but they're moving, they're acting out their dreams. That's what we mean by dream enactment, is actually acting out or talking in your sleep, vocalizations. And for some people, like I said, it might just be these minor talking. Some people it's more severe, and obviously it can be dangerous with falling out of bed. So there's things,
Right.
definitely talk about this with your doctor, because there are ways to treat it. And there are strategies, such as especially in my patients who we have them on medicine, but they still do it, maybe, get the mattress low to the bed or something like that. But melatonin, actually, that's something that's been really cool in the last few years, that we've learned that melatonin can be very effective in helping to manage REM behavior.
Okay.
And often, so, when you get it over the counter, it's usually 3 milligrams or 5 milligrams. And in the trials, it was therapeutic from like 5 to 12 milligrams. So don't give up on it. Again, work with your doctor
To find what
to
works
find
best
that
for you.
dose that works
Yep.
for you. Yeah.
Okay. So next I have a couple questions that perhaps are a little bit outside of what we normally think about, but can umbilical cord stem cells be used to help for a cure?
A great question. And certainly we're learning more about the benefits of stem cell research. At this time, we don't have any approved therapies utilizing stem cells. And the initial trials, were a little bit inconclusive, but there's at least one study I know about that's going on right now. So I think more to come with stem cells. That's exciting.
So there's lots more to be learned.
Yeah, lots more.
How about cold showers? Are they helpful?
Yeah, great question. I don't know. I mean, certainly and I learn from patients, I learn from the community, and people have these little tips that seem to work to help maybe calm and I don't know which symptom we're talking about, but tremor, right. People have a lot of ideas or strategies that work for them, such as not drinking too much coffee. If I have an important, talk I'm going to give and I don't want my tremor to be disruptive, I don't drink coffee. Or, so I don't know if a cold shower might work the same way. But we certainly I hear about this. I hear about, when I was up in the mountains in Aspen, my tremor was better, so I think there are environmental factors that can help. I don't really know the mechanism. Like I said, I think it's more of a relaxing thing, but
So
yeah. And then I do hear people say their symptoms are worse in the summer or worse in certain times of the year. So I don't know.
Once again, perhaps part of the mystery of
Parkinson's and yeah.
And here's another interesting question that relates to, you had mentioned this very early in the presentation about eye blinks. So someone is wondering about not being able to open their eyes, and maybe this lasts for up to 10 seconds. Mm-hmm. Is there anything that can help that?
Mm-hmm. So what you are referring to is something that's called eyelid opening apraxia or blepharospasm, where there's actually it's hard to volitionally open your eyes at times, and not everybody experiences it, but some people can. And actually a beneficial treatment maybe to think about and to talk about with your doctor can be Botox therapy. Botox can help basically weaken those closure muscles so that it's more easier to open them. But what I would say is similar to the freezing of gait, sometimes it's also just finding this cue or this way to override it. So if you're having trouble opening it, sometimes the more you focus on opening your eyes, the worse it gets. And so maybe doing something else, chewing on a candy or something like that might help. Again, everybody's different, but sometimes this overriding strategy, but Botox can be helpful for that.
Okay, great suggestion. And I think our last question for today, and it certainly is a very important one, and I think applicable across the board. But one of our viewers asked about, I just can't afford the copay for the medication prescribed.
Yeah.
Should that person pursue, talking with the doctor about something else? And when you encounter that, Dr. Amodeo,
Yeah.
do you have referrals for your patients of perhaps where they might be able to seek assistance with their copays?
Yes, that's one of the, well, there's lots of things, but that's one of the things that I probably get most upset about in this, world is cost prohibitive medications, and particularly the new kids on the block. So these new agents can be more expensive, and sometimes it can be cost prohibitive for a patient. And so, but if it's the right treatment for you, I don't want that to stop you. If you can't pursue another medicine that's less expensive, which I often will try to work with, is there something that's more affordable that works? But if this medicine works for you, I don't ever want it to be, a total barrier. And so I often work to try to find other avenues, which may be, going on a website like GoodRx or and finding where you can get it the most affordable. I often tap into social work teams to see what we can do. Are there ways to help support them with coupons or something like that? Or like you said, I actually do through the Parkinson's Foundation, at least when I remember we had a resource for grants, and sometimes so I would often direct them toward a grant that might be helpful in managing their medications.
Absolutely.
Yeah.
Absolutely. I would encourage, once again, use that helpline number, call our specialists. They hear from so many people across the country and beyond, and they have accumulated a huge amount of knowledge. So for anyone who might be in need of that, please contact our helpline.
Right. You're not alone.
No, not at all.
So that's
not
just
at
a
all.
wealth of information because people have looked into this. Yeah.
And we certainly want to encourage people to be able to get whatever they can to help manage this disease. So Dr. Amodeo, this has, I think, been a marathon for you. I thank you so very much for all that you have done to help us put this program together. Dr. Amodeo is an official Parkinson's Foundation volunteer, which we're very, very fortunate for. And if any of you are wondering, you will, after the presentation today, you will receive an email with the slides. We have recorded this, so if you need to come back and check any part of it, you certainly can. It will be posted in our YouTube channel for the Parkinson's Foundation, but you'll have a direct link. And least but not last, please make sure that you help us out. Tell us what you think in our evaluations. We really would love to get your feedback and need that so much so we can continue to provide as much information that's pertinent and beyond. So to finish things up for today, I just wanted to share once again and encourage you to take advantage of our supports and resources that are out there. For most of you joining us today, you know that the New York, New Jersey chapter of the Parkinson's Foundation is in fact your chapter, and we're very honored to be here working on your behalf. But maybe you travel to some other places during the year, or perhaps you know other people in the country, or you're on the webinar, but you're not necessarily from New York or New Jersey. All you need to do is go to locate your local chapter, is go to our website, parkinson.org/chapters, and you will see all 17 of them listed there, and you'll be able to once again find what is the chapter that's closest for you. Also, I'd encourage you, we perhaps have been very redundant about this, but call our helpline if you have any questions. If we didn't get to a question somehow, I think I covered almost everything, but if we didn't get to your question, please call our helpline. They are more than happy to assist. If they don't know an answer, they find out, and they are well equipped to help answer and assist in any way. I also wanted to mention that on our chapter websites, if you're interested in finding out what are the area wellness programs or support groups, we have them all listed now for across the state, across both New York State and New Jersey, and you'll find that resource in other chapter websites. So please feel free to visit that. And lastly, we just announced our next round of community grant funding. If you're interested in learning more about how organizations, nonprofits can apply to the Parkinson's Foundation, provide programming, you should check out parkinson.org/community grants. And lastly, one more time, for everything you need to live better with Parkinson's, we refer you to our website and parkinson.org. Remember, don't use an S, parkinson.org, or our helpline, 1-800, the number 4PD-INFO, or 473-4636. And last plug, if you are someone relatively newly diagnosed, meaning about less than 5 years or less, please contact our helpline for the specially designed newly diagnosed packet. And lastly, I know there's a lot of information coming your way. I wanted to actually make sure that you're all aware of another way you can stay connected and plugged in and help reduce that social isolation by joining us for our PD Health at Home series. This is a program that just started back in April. We keep updating it and changing it. Every Monday, it's Mindfulness Mondays, Wednesday, Wellness Wednesdays, and I mentioned already Fitness Fridays. Great videos. Everything we've done has been posted. You can go back and visit, sign up for the upcoming programs. We'd love to have you be part of PD Health at Home. So my best wishes to everyone to stay safe. Thank you for joining us today. We truly appreciated you being with us. Thank you to all of our wonderful silver and exhibitor sponsors. Thank you. And I look forward to when we get to meet again in person. Take care.